if you go to med school or you go to PA school, do a rotation and see, like, you'll know right away, this fits me, or like, I don't want anything to do with this ever again.
eShadowing, session 5. Dr. Elaine Reno. How are you, my friend?
Good. How are you?
I am doing great. We are joined by at least 1,500 students right now live with us, which is very fun. Thank you, everyone, for showing up here for, I think, what will be a little bit different night of eShadowing, something that the University of Colorado. Is it the emergency medicine or is it wilderness medicine that's doing the fun shadowing stuff?
It's both. We're both.
Nice. All right. They are intertwined. So some fun things happening in the sim lab at University of Colorado School of Medicine that we'll be showing you tonight, and we'll send out some links for you to actually get more of these as well. Before we jump in, I want to do a quick little housekeeping, just eShadowing in general. So as we're recording this, it's October 26th. 2020. We are live right now. If you're watching this on replay, thank you for showing up. You can watch this on replay through the Webinar Jam platform through Sunday night and still earn credit. Now, for the thousands of students earning credit every week, the platform seems to be doing its job. I've had 1 or 2 or 3 people email me saying it's not working. I'm not going to change time for the 3 of you. I'm sorry. So make sure that you're logged in, ready to rock and roll in the platform. If you're watching, you are logged in, even if you probably didn't log in. The quiz links, the replay links, the registration links, everything lives at eShadowing.com. So check that out. And then one other thing. In the next week or 2, we are going to start eShadowing for pre-PA students. I have an amazing PA who's going to host eShadowing for pre-PA students, and we'll get that going, bringing on PAs as guests. And Dr. Elaine Reno probably knows a few that would be awesome guests. So
yeah, I have some if you need names.
Yeah. All right. So with that said, if you are rocking and rolling, let's go and get started. So Dr. Elaine Reno, you are an emergency medicine physician. What is the biggest myth around being an emergency medicine physician?
Ooh, there are a lot of them. I think the biggest myth around being an ER doc is that it's all like, I don't know, gunshot wounds and car accidents and heart attacks. And actually a lot of what we do is like more bread and butter medicine and reassurance, like that your belly pain is not appendicitis or your chest pain is acid reflux and not heart attacks. Maybe that's the biggest myth. So
yeah, I think ER as a TV show, kind of ruined emergency medicine for a lot of people. It's a lot of boring kind of bread and butter stuff. And we've had a few guests now that have talked about, as you are deciding on a specialty, you really have to enjoy the bread and butter. What's the bread and butter that you really enjoy as an emergency medicine physician?
I think that's a good question. So I like everything about emergency medicine, but the thing that I probably like the most is that, like, in America, you can go to an ER for any reason, no matter what your insurance is, no matter what your financial resources, whether you're like the CEO of Amazon or whether, you're homeless and you have no access to resources. And so I like the ability to care for everyone from all walks of life and provide that care, especially when people don't have other access or ability to get care. And so for me, like, getting to be essentially a resource for anyone and everyone, no matter what, is important to me. And I like that aspect of my job.
Talk about the specific law. I think the law name always comes up and people might not recognize that.
Yeah, so there's actually a law that ensures that, and it's called EMTALA. And I'm not a lawyer, but essentially it says, like, if you have an emergency medical condition or you're in labor, legally, you have the right to seek medical care and get stabilizing medical care, regardless of your ability to pay or your insurance status.
Yeah.
So,
EMTALA. That's a good one. Yeah. One of the things that I think I hear a lot from emergency medicine physicians is the kind of differentiation between primary care and emergency medicine, and how primary care a lot is done in an emergency room. Talk about where you see kind of the future of the emergency department and how they fit in with primary care.
I think that's a great question. So in a perfect and ideal world, every single person would have a wonderful primary care doc who they can access regularly, and that they have a good relationship with. I don't think the ER wants to replace the job of the primary care doc by any stretch of the imagination. And primary care docs are essential to like community wellness, and essential. Everyone should have a good PCP. I have a good PCP, even though I'm an ER doc. I think when that doesn't happen, then sometimes the ER ends up filling that role. But the emergency room I work in, people have done really good work in trying to, when we see someone for diabetes who has a new diabetes diagnosis or doesn't have access to their medicine, we try really hard to to recognize that and then to tie people into the services that they need, so that they can seek care through a primary care doc for follow-up care, so that they don't have to return to the emergency room for ongoing care, and so that they can get the care they need from their primary care doc. And we have people whose job it is to do that in the ER 24/7, to try and get people tied into the resources they need. So I think that the ER is a safety net, but I also think it's really important to get people there into the care that they need on a daily basis, because the ER, while we do some aspects of primary care, really primary care docs are excellent, and they're there for a reason, right? You need someone who manages your blood pressure every 3 months if you really have problems with it, or manages your diabetes and is keeping an eye on you. So
a couple questions that have popped up before we jump into the cases. Discuss the level of trauma centers and what that relates to with the emergency department.
Yeah, that's a good question. So there are varying levels of trauma centers, and I won't go into all the details, but essentially it has to do with the resources you have available. So I work at a level 1 trauma center, which is the highest one. And so it means essentially have everything. So we always have an ICU staff. We have trauma surgeons. We have neurosurgeons. We have orthopedic surgeons. We have other surgeons that I'm forgetting. And they're ready and available and in-house. We have anesthesiologists. We have an ICU that is capable of taking care of trauma patients. And so everything for any traumatic emergency, we have available. And then there's sort of varying levels depending on, do you have a trauma surgeon? Do you have an ICU? Do you have an anesthesiologist? Stuff like that, to determine where trauma cases go, depending on the severity of the trauma. So, and usually if a person is a really sick trauma and they don't end up at a trauma center, often they can be stabilized and then flown to what we call a higher level of care, which would be a level of care with more resources, right? So if you're a community ER and you don't have a ICU available, then if your patient needs an ICU level of care, then you can fly them or drive them, depending on the distance, to a higher level of care. And so where I work, we get actually a lot of, and not just trauma, but all different types of critically ill patients. A lot of patients flown, not so much from the Denver area, but from some of the outlying, very rural areas, and even sometimes some of the other states, to get in what we call an escalation of care. So
one of the questions that always comes up is that you have to love chaos and just the high kind of acuity of the emergency department. Is that a myth around being an emergency medicine physician?
I think you have to be very comfortable in an element of, maybe chaos is the wrong word, but you have to be comfortable with the lack of control. Like, so my job is totally unpredictable. I mean, the only thing that's predictable about it is the lack of predictability. And so, like, you know, I can be sitting there and someone comes up and like delivers a baby in the ambulance bay, or like, you know, has a gunshot wound and like drives to the front doors of the emergency room. Like, all of those things happen to me, maybe not on a daily basis, but things like that occur regularly in an emergency room. And so you have to be comfortable with the unpredictable nature of your job, and the fact that it's like always different and can get very, very intense. Even if a lot of it is what we call bread and butter emergency medicine, not all of it is. I think the true test is just to like get into an emergency room. If you go to med school or you go to PA school, do a rotation and see, like, you'll know right away, this fits me, or like, I don't want anything to do with this ever again. So, because I think it's just a really unique environment.
Yeah. All right. I'm excited to jump into these cases. So we're going to jump into the first one. I think you and I should still be able to talk, so you can let me know when to stop and where to go from here. So,
okay. Can I give like a little disclaimer?
Yeah,
first?
Let's do it. Yeah.
Okay. So, I work for the University of Colorado in the emergency department. And we do lots of like pre-PA, pre-med student, pre-NP student education. And so we know that shadowing is impossible. In fact, our hospital canceled all shadowing because of COVID-19. And so we filmed 5 shadowing videos in our simulation lab, and we're going to play one of them and discuss it today. And Ryan will send you the link. There's 4 more if you guys want to watch them. If you want shadowing credit from the University of Colorado, you can do that too. The videos are free. And then if you provide us feedback, if you like this model, we'd like to continue to film them in the simulation lab, assuming you guys like it. And it's designed to simulate a clinical visit. So essentially, like if you were tagging along on my shoulder after a real hospital visit. So.
Yeah. Cool. All right. So this is my first time playing a video, so we'll see how it works. We'll see. All right. Let's rock and roll.
Also, Ryan, there's like a million comments on the side. If there's some way to like send these to me and I can answer a bunch of them.
Okay.
Hey, what's going on? Dr. Lemry here. How are you?
Good. How are you doing?
Good. Good. So, just saw your chart. It sounds like you had a seizure. What's going on?
Yeah, I was at work. I was at my computer at my desk, and apparently I had a seizure.
All right. Who did your coworkers see this, or?
Yeah, my supervisor.
Okay.
He found me at my desk.
Okay. So you have a history of seizures.
I do. I have epilepsy, but it really hasn't happened in several years. So
Okay.
I'm on Lamictal.
What do you take for it?
Lamictal.
All right. And you've been taking your meds as scheduled?
I'm pretty good about it, decent, but
okay.
not lately, not as much.
Okay, so maybe a little lapse. Did you take it today?
I did.
Okay.
I did.
All right. A couple more questions. Are you taking any other meds?
No.
Any allergies to medicines?
No.
Okay. Sometimes with seizures, people have substance abuse issues. Any heavy drinking or?
A few drinks here and there, not anything out of the ordinary.
Okay, you never get the shakes if you don't drink?
No.
Any other drug use at all?
No.
Okay. No. All right. Any other medical problems we haven't talked about?
No, nothing else.
Any surgeries in your history?
Like when I was 17, I had a tooth extracted, but that's really it.
Okay, that's it. All right, a couple other questions for you. Any headaches or vision changes or neck stiffness?
Just.
All right. Hey, he's seizing. Guys, he's seizing. Scarlett, can you give me 2 milligrams of lorazepam, please? Need some suction here. Okay, you got an IV there?
Administering.
Okay. All right. Thank you. Thank you. Okay. He's got a lot of secretions here. Scarlett, can you help me roll him?
Yep.
Please suction for me. Let's get him on some oxygen. Roll him on his side, please. Okay.
Suctioning.
Good. Let's put him back. Scarlett, will you put his mask on for me? Okay, we'll pop this on. He has a history of seizures, so he got the lorazepam. We're probably going to do okay. Let's keep an eye on him, and let's monitor him for a little while, make sure this doesn't recur, and then we'll come back and reassess him a little bit.
Okay, sounds good.
Hey, Drake, how you doing, buddy?
Doing all right. I'm just really tired.
Yeah, okay. So we know by now you had a seizure here. We gave you medicines to protect your you from having another seizure. You know, in and of itself, this isn't terribly concerning because you have a history and we know you have this disease. Mm-hmm. You did say something, I don't know if you remember, before you seized that you maybe haven't been super compliant with your medicines. So one of the things that we're going to have to talk about is make sure you're taking your Lamictal as prescribed, okay? Because when you don't get on those meds regularly, mm-hmm. you're not protecting your body from having more seizures.
Yeah, okay.
Does that sound all right?
Yeah. Yep.
We're going to keep an eye on you for a little bit. Looks like you're recovering well. And is there someone that can come get you before we send you home?
I can call my mom.
You can call your mom? Okay, cool. So that'll be our plan. But, you know, we'll keep an eye on you. We'll probably get you some drinking something, making sure you can take food before we let you go home. Okay, pal? Okay. All right, we'll keep an eye on you. Good.
Thank you.
So the first case we saw is a 25-year-old man with a seizure history. Generally, when patients like this come into the emergency department, it's all about the history and compliance on medications. The fact that he had a seizure in front of us wasn't necessarily concerning, given the course of his history. We do want to make sure that he gets supportive care, thinking about airway, oxygenation. Most seizures actually go away on their own, so you don't necessarily have to give medication for that one-time seizure in front of you in the emergency department. Although we chose to do that because what that does is it protects him using a benzodiazepine in the short term while we figure out what his medical compliance was. His seizure was otherwise uncomplicated. They often have a post-ictal state where they'll be confused for about 20 minutes, 40 minutes after the seizure, but then they come around and wake up and are able to give us a good history. And you can see this is a very classic case of somebody who wasn't taking their medications, and we attributed that to the cause of the seizure. One other thing you always have to be thinking about is a drinking history. Remember, alcohol particularly is a depressant, so if patients are taking lots of depressants and then for some reason don't, their body goes into an excitatory state, meaning a bad drinking history, and for whatever reason, whether through illness or their own choice to sort of get dry, they can put themselves in big danger in going through alcohol withdrawals, which often manifest as seizures. So it's a really important part of the medical history. The idea of rolling him out of his side when the seizure stopped, but he had this sonorous breathing pattern, was that he was now at risk of swallowing his own secretions, which can be very dangerous to the airway. So by rolling him on his side, all the secretions come out as opposed to back into the airway. And it also allowed us to suction him and get those secretions out. It doesn't last very long. Usually people with seizures, when they extinguish, are able to protect their airway shortly thereafter. But for that critical few minutes after their seizure stops, that's an important part of supporting the airway. Another thing you always have to worry about is trauma secondary to a seizure. Remember, seizures come on quickly, and patients can often fall in precarious places on concrete, hit their head, dislocate their shoulders. So a good post-seizure trauma exam, looking at any abrasions or tongue biting, making sure that all their extremities are intact is really, really important. That part we didn't include in our secondary assessment, but it'll be very important after a seizure to make sure that there's no secondary trauma. In some extreme cases, what we call as refractory seizures, where the seizure just doesn't stop, that mandates an intensive care unit level of care with lots of drugs and supportive care. That's very rare, but that's called status epilepticus. And again, that's something that can happen with seizures that don't go away, and that can be very dangerous. So it necessitates a lot of hands-on and supportive intensive care unit care.
All right, so that was exciting. Elaine, what do you think about bringing someone on to discuss that session?
Sure. Do you want to bring a student on?
Yeah.
Okay.
All right. So if you want to come on, you need to be tech savvy enough to know how to give Google Chrome or Safari access to your webcam and sound. Raise your hand to speak and we'll pick someone here. All right, let's
I feel like
try.
my room is getting really dark. Hold on a second.
Have at it. All right, I've picked someone. We'll see. I'm gonna add one other person. We have Rhea.
Hello.
Hello. How are you?
Good, you?
Good. So, Dr. Reno, why don't you ask some questions about this?
Yeah. So, why don't is it Rhea or Rhea?
It doesn't matter. Ria's fine.
Of
course it matters.
I think it matters a lot.
Ria's fine.
Rhea. Okay. Rhea. So do you want to give me kind of your impression of the case overall and what your thoughts were? And to clarify some points I saw in the comment, yes, he is an actor. And my very favorite, and he did a great job. I totally agree. I have no opinions on the cameraman except it's an engineer in a simulation lab with no camera training. So I think that's probably the best you're going to get for simulation lab. And my most favorite comment of all was the person who said that the actor should have committed to peeing their pants to make it more realistic.
I saw that one.
We did not ask that of him. So, all right, Rhea, you're up.
All right. So you're asking for my impression about the situation, right?
Yeah, and your impression of the case.
Oh, I think the case was quite interesting. Earlier you said that in emergency medicine, the most predictable thing is that nothing is predictable, right? And I think in that case, the doctor was doing a history check, and just in the middle of it, suddenly the patient started seizing. I think that was quite unpredictable, and in return, the doctor knew immediately what to do, and I think it was very impressive that they were on their feet and they knew what to do immediately. So,
what do you think? And you guys she can answer this, or we can answer in the questions. So, one thing about when we think about taking a history and doing a physical exam with patients, particularly with the history, one thing that this guy's name is Dr. Lemry, Jay Lemry. One thing that he did was he started with very broad questions like, oh, what brings you here? And then he developed what's called targeted or narrowed questions like, have you forgotten to take your seizure medicines? Do you ever drink alcohol? Things like that. What do you guys think of that as an approach?
I think, oh, sorry, should I answer this one as well?
Yeah.
Sure.
Yeah, I think it's quite, like, it narrows down the diagnosis of as to why he had a seizure in the first place. And it helps a lot with pinpointing certain areas and helps with diagnosis, I guess, in general.
Yeah, and actually there's like some data that shows if doctors are actually really bad at interrupting, it turns out we're terrible at it. And so like if you literally go to the patient and you're like, oh, what brings you here? And then you just stay quiet for like 1 to 2 minutes, they give you most of the information you need. But I feel like every time I see a study, it says the average doctor interrupts 20 seconds in or something like that.
I was going to say, I think it's 17 seconds I've seen.
17. We're getting less and less attentive, apparently. So when I take a history, I always try and think about, like, give them like just a couple minutes to get it out, and like try not to be the person that interrupts 17 seconds in. And so sometimes I try and do that by because I'll know the questions I want to ask them and I won't want to forget. So especially early in my training, I would actually write those questions down while they were talking so that I would not interrupt, but know to go back to them. And so we try and do like an open format and then narrow as we go. So what do you think of who's been hospitalized and seen like an internal medicine doc versus the history that we take in the ER? Like, what do you think are differences in how different types of docs get histories from patients and the information they collect? What do you guys think of that?
Go ahead. What do you think?
Well, I've only really been to the ER, but I would say that if you go to an internal medicine doctor, it'd be more specific towards like the internal med side. As for emergency, it could be anything. So you just want to do, and like you said, you just want to do a more open format and then make sure you narrow it down specifically to how their history and past medications have been. So you can tailor it to that, I would say. I don't know if I answered that correctly.
I think someone in the comments had a good comment that was talking about medical ICU histories and how they take more time, and it's gone because there's too many comments. But usually in the ER, seizure tends to be maybe a more broad history because there's a wider what we call differential diagnosis. But often, like if you're going to your family medicine doc for an ankle sprain, they'll do a very focused history and physical exam based on the ankle. But if you're going for something more broad, like unexplained fatigue or chest pain or something like that, like then the history gets wider and more extensive. So in the ER, really depending on what's happening, we tend to take more focused history and do more focused physical exams versus like if you're admitted to the medicine ward, they tend to take longer history and physical exams, I think, than we tend to do. And then each specialty is sort of specific, right? If you go to the surgeon, they really want to know about your surgical history. Like if you, like I have a 3-month-old. So when I was going to my OB, like they really wanted to know about my first pregnancy versus when I go to my primary care doc for an ankle sprain, they are really not so interested in how the first pregnancy went, and they're very interested in, what's wrong with my ankle, because that's why I'm there. So there's different histories and physical exams, different types of physicians perform based on what they're looking for at the end game. So,
alrighty. So let's we'll say goodbye to Rhea. She should jump back on. Something just to bring in a little bit more of the quote unquote shadowing side of this. So if a student was literally shadowing with you in that moment, what should a student do who is a shadow if a patient starts seizing, the room gets a little chaotic?
That's a great question. So first, recognize that sometimes the room feels really chaotic, but I think if you notice, like, Dr. Lemery was not stressed out during that situation, and there were lots of questions about, like, how do you remain calm? The reality is, I think calmness in a clinical situation like that is trained into you. Like, there's some inherent characteristics, but also Dr. Lemery is calm because, like, the person's having a seizure, like they have a seizure disorder, like they're fundamentally going to be okay. Like he knows the next 15 steps to take to stop the seizure, or if the seizures don't stop, to like help the patient. And so really calmness has a lot to do with training, right? And a lot of training for example, things like, and so a lot of the training in a critically ill patient is like, not that it's similar, but the same things are important every time, right? Like you need an airway open, like you need to be able to get oxygen in, you need to be able to breathe, you need your heart to pump, like, and we work through those algorithms with whether, you were shot in the chest, or whether you're having a seizure, like, or whether you have COVID, or whether you have a COPD exacerbation, like the fundamentals are the fundamentals. And so I think it's easier to stay calm when you, in your brain, know the next 10 steps you're going to take. And so he was like, I'm going to stop the seizure with medicine, and then I'm going to roll the patient into the recovery position, and then I'm going to put them on oxygen, and then I'm going to see how their airway does. And he knew all of those steps the moment they started seizing. Yeah. And so in terms of calmness, like I think that has to do with it. And that's one of the things about emergency medicine. If you're shadowing, to get back to Ryan's question, because I diverted really far away. If you're shadowing and the situation feels chaotic or something like that, the first thing is always personal safety, right? And so, no one is going to be shadowing in the time of COVID, but like in a situation like that, that's a high risk for people to be exposed because the mask came off and the patient was having secretions. And so first and most important is safety. So if you're in a situation that appears unsafe to you personally, like you need to remove yourself from the situation. Although realistically, you should never be in an unsafe situation shadowing. The second thing is like when I have shadowers, I give them a spot to stand, which is next to the scribe. And I tell them if things get chaotic, back into the wall and stand there. And then if anyone ever asks them to leave the situation, like even if they think it's unfair or they don't understand why, please just do whatever is asked of them. And then when the situation calms down, we can readdress it, like why they were either asked to leave. Maybe it's that there's a risk they don't understand, like the patient started seizing and the physician was like, this could be bacterial meningitis. Like, I want everyone out of the room so that they're not exposed. And then once we rule that out, then we'll bring people back in, things like that. And so, so I think personal safety is important. And then like just staying calm and, sort of backing away and shadowing. If you're ever in a situation where, let's say you're walking by that room to go to the bathroom and the patient starts seizing and no one is there, then I would go get help. So.
Very cool. All right. Should we do another one?
Sure. Does anyone have pressing questions first?
I've been scanning the questions. Just a lot of basic stuff. Nothing like huge that I think would be a ginormous benefit for everyone. Okay.
After the second one, then we'll talk about what's a differential diagnosis too. Does that sound reasonable?
That's good. All right. So let's play this next one.
Hi, Scarlett. My name is William Mundo. I'm one of the medical students that will be taking care of you.
Hi, how are you?
I'm doing great, thanks. I heard you're not doing too well.
Yeah, my, stomach hurts up here, and it's just kind of getting annoying, and, time to come in and see what's going on.
Yeah, I'm really sorry to hear that. I'm really glad that you decided to come in and so we could check that out. Can you tell me a little bit more about what's going on with your stomach pain?
I mean, it's definitely higher up, kind of like here. Sometimes it burns, but not always. So I'm sorry, I don't know 100%. I'm not really paying attention to when, it hurts. Yeah. It just hurts, and yeah.
Okay, yeah, no worries. You don't need to apologize. I know sometimes with the abdominal pain, it can be really hard to pinpoint it, so we'll make sure to get to the bottom of that, okay? Is there anything else in particular that brought you in today besides your abdominal pain?
No, that's it.
Okay, so just your abdominal pain, correct? Mm-hmm. Okay, great. And can you tell me when you first started to notice this pain?
It's been going on for a little while. I don't really remember when it started, but it's definitely been bothering me more recently.
More recently, okay. And would you say a couple of months, days, more recently that it's been bothering you?
Probably a couple of weeks.
A couple of weeks?
Yeah.
Okay. Okay, and is there anything that in particularly makes it worse?
Not that I've noticed. Okay. I'm not really sure.
Like what about like when you eat? Or like when you drink water or anything like that?
I pretty much eat all day since I'm working from home, so it's hard for me to distinguish you know, if it's at meals or I'm snacking, it kind of just pops up.
Pops up out of nowhere. Okay. And do you, by any chance, notice at what time it kind of tends to pop up throughout the day? Is it more like at night? Is it more in the morning? Kind of throughout the entire day?
So probably more in the evening time.
In the evening time.
Yeah.
Okay. And can you tell me more about what kind of things you've done to help your pain?
So I take Tums and Tylenol and ibuprofen, the stuff they tell you when you like look it up online. So.
And how has that been?
I mean, it hasn't really helped. Not as much as I thought it would.
Yeah, I'm really sorry to hear that. Let's see if we can hopefully find out what's going on and make you feel better, okay? Is there anything in particular that, you know, you think would help for us to, you know, help you alleviate this pain?
I'm not 100% sure. Yeah, I'm just looking for some kind of relief.
Yeah,
it's starting to affect my daily life.
I'm really sorry to hear that. And can you tell me more about your daily life?
Yeah, so since COVID and everything, I've been working from home, which is good and bad, but I'm trying to make the most of it, you know, doing some day drinking while I'm doing work, kind of makes it a little more tolerable. So, and then going out with friends when I can and, you know, exploring downtown.
I hear you. Yeah, it kind of sounds like COVID has had a pretty significant impact on your social life. Does that sound correct?
Yeah.
Yeah, I'm really sorry to hear that. So, I mean, hopefully we can see, you know, what's going on and, you know, get you back up to your social life, okay? Before we move on to the physical exam, just to make sure I don't miss anything else, I'm going to run through some standard questions that I ask all my patients just to make sure that we are taking a comprehensive history. How does that sound?
That's fine.
Great. So I'm going to grab your chart and just kind of go through some things with you, okay? So tell me, Scarlett, do you have, I don't see anything on your medical chart. Do you see a doctor regularly for anything?
Once a year, just for the annual physical my insurance covers.
Okay. So it sounds like overall you're pretty healthy, just going and getting your checks.
Yeah.
Okay. And have you had any surgeries in the past before?
No surgeries.
No surgeries. Okay. And you did say you go to the doctor regularly. Do you take any medications when you go to your doctor? Do they give you any medications?
Yeah, I just get my birth control refilled when I'm there.
Okay, great. And what kind of allergies do you have?
I don't have any allergies.
No, that's great. That's really great to hear. I have terrible allergies, so I'm really jealous. So, you know, you said that you've been having, you know, this abdominal pain and it's impacting your life. Do you know the abdominal pain has been, you know, going on with other things? Maybe like a little bit of nausea, vomiting, or diarrhea?
Sometimes I'll vomit, but I don't like to vomit, so I try to hold it in, which doesn't help either.
Yeah, that sounds rough. So it sounds like vomiting is also, you know, causing some problems for you. Okay. And tell me, in regard to, you did say that you were, you know, going out a little bit and having some drinks. How often do you go out and drink?
So, like, out on the town, I'll go maybe 4 times a week.
Okay.
You know, I gotta support the small businesses, so.
Yeah, okay, 4 times a week, okay. Absolutely. And when's the last time you had a drink?
Let's see. Last night.
Last night? Okay.
Yeah.
Okay. Great. And I was just asking just to make sure we can get everything and have a comprehensive history, okay?
Okay.
So before I move on, is there anything else that you'd like to share before I do a physical exam?
I think that's it.
Okay, sounds good. So what I want you to do first is I'm going to start by examining kind of your eyes, just to kind of make sure they're symmetric, in which they look pretty symmetric, okay? And then now what I'm going to do is I'm going to kind of touch your lymph nodes below your chin, okay? Just to tell me if you feel any pain there at all.
No pain.
No? Good. Okay. Good. And now the next thing I'm going to want to do is listen to your heart.
Okay.
I'm going to check your cardiovascular system, okay? So you could just breathe regularly. Okay, you have a good heart. Now, since I have you here, I'm just going to take a listen to your lungs as well, okay? So I need you just to take some deep breaths for me. Great job. Great job. I'm going to come over here. Good job, and check this side. Great. Front sounds great. I'm going to take us into the back real quick, all right? So I can help you out. And just take some deep breaths for me. Okay. Good. Again. Good. Again. Great. And I'm going to touch your spine over here. Do you feel any pain back here when I touch?
No.
Okay, good. So have you relax for me? So now what I want to do is I want to take a look at your abdomen. How does that sound?
That's fine.
Just to make sure we get to that because I know that's bothering you.
Okay.
Okay. So as I kind of poke around, I'm going to stay away from there and work my way to the abdomen, okay?
Okay.
So I'm going to do some light palpation. Okay. Do you feel any pain when I press here?
A little bit there, yeah.
A little bit? Okay, what about here?
No.
No? Okay, and I'm going to go a little deeper now. How about now?
No.
No? Okay. I'm going to go in this area. How about there? Yeah, right there? Okay. Over here?
No.
No? Okay, good. So the last thing I'm going to do is just do a really quick neuro exam, okay?
Okay.
So if you can do this for me, I want you to touch your nose, okay, and then touch my finger. Good. Again. Good. Again. Good. And then now with the other hand. Good. Good. Okay. And then the last thing I'll have you do is I'll just have you stick your hands out for me like this. Okay, and try to hold them as still as you can. Okay. Have you noticed that before?
I mean, I thought just because I was nervous or something, like, I didn't think it was anything serious or maybe caffeine.
Yeah. Okay. You drink a lot of caffeine?
Yeah.
Here and there? Okay, sounds good. All right, well, what I'm going to go do now is I'm going to go talk to my supervising physician.
Okay.
And we're going to kind of come up with a plan to see how we can move forward to make sure that we can make you feel better. How does that sound?
That's fine.
Great. Do you have any questions for me?
No questions.
Okay, be right back soon, all right?
Okay, thank you.
Hey, Will. So I saw you saw Scarlett. Tell me what you think's going on.
Yeah, absolutely. So Scarlett's our previously healthy 25-year-old female who's coming to us today complaining of abdominal pain. She doesn't really know when it kind of started to happen. She explains it very vague in terms of when she first noticed it, but she is saying that it's contributing a lot to her daily activities of life and not being able to engage in things that she enjoys. She says that right now, the only thing that she has been doing for it is taking some ibuprofen, a little bit over-the-counter medications, but it kind of seems to still be causing a lot of pain. In regard when she notices it the most, she notices it the most during the night. And she doesn't say that it's associated with eating or any other symptoms like that. She does say, though, that she has been experiencing some nausea and vomiting as a result of the abdominal pain and has been going on for quite some time. She doesn't have any relevant past medical history, only takes vitamins and birth control for medications, doesn't have any allergies to anything. And in regard to her social history, she did say that she was really having some issues with what COVID has been going on, and she did endorse drinking a couple of drinks pretty frequently. She said that she was drinking at least 4 times a week, and her last drink was last night. However, when I talked to her about, the drinking, it doesn't really seem like that's bothering her as much. And she's kind of really stuck to the abdominal area that's causing a lot of issues, not really much so the drinking. Her vital signs, heart rate is 106, blood pressure is 160/90, and her oxygen is 98% on room air. Upon physical exam, she didn't have any abnormal findings besides having a little bit of tremor when I asked her to outstretch her hands. And she also had a little bit of tender palpation when I palpated on her epigastric region. So Scarlett, our 25-year-old previously healthy female, is presenting to us with abdominal pain. For problem number 1, I really think that this may be dyspepsia, complicated by alcoholic gastritis, just because given the complicated nature of the social history that she's been experiencing and also her alcohol frequency of intake that she has.
Okay.
To kind of work that up, I think starting off with some anti-acid medications might be good for her, and just to kind of monitor that. But I also think we should address the issues that she's been having with alcohol, so I think it might be a good idea to get counseling involved.
Okay.
The second problem is the nausea and vomiting. I think that's secondary to what's going on, so I think by addressing the primary problem she's presenting with, we'll be able to address her other issues as well.
Let's just make sure we send some basic labs on her, CBC, I think chemistry, perhaps some GI, LFTs, and a lipase for her. Certainly a pregnancy test and a urinalysis, but otherwise I think that sounds great, Will.
Great, I have all those down. Hi, Scarlett, I'm back again. I'm here with Dr. Lemry, who's my
Hi,
attending
great to meet
physician.
you.
Nice to meet you.
So I got a chance to talk to Dr. Lemry about what's going on. And he has maybe a couple more questions, and we can go from there. How does that sound?
That's fine.
Yeah, so one thing we want to make sure that we don't miss anything else, so we're going to draw some basic blood work. We need to check your urine for some of the basic workup for abdominal pain. One thing we were talking about is that maybe your drinking pattern may be contributory to this, and we're seeing some other signs that maybe drinking is affecting the presentation. You're a little tremulous, and I can see your heart rate's a little high. So if you're okay with it, what we'd like also to do is have one of our counselors come talk to you about maybe resources that you could benefit from. Does that sound okay to you?
Yeah, that sounds okay.
Okay. Yeah, I know this is tough to hear all this, but we're going to make sure you get the care you need. So, so thank you. Okay, great. So, Will, that was a great job. You're a third-year med student, and when you went in and spoke to our patient, you picked up on something. What were you? She came in with abdominal pain.
Yeah.
What else did you think was going on, and what kind of got you there?
Yeah, so when she presented with abdominal pain, it's a really broad differential, so it's really important to key in on the history, just because that will allow you to determine what questions you need to ask next. I think what really tipped it off for me, though, was when she started talking about the stress she's experiencing in her life and her use of alcohol and how that relates to her abdominal pain.
She wasn't very forthcoming, right? I mean, she wasn't saying, yes, I have a bad alcohol use disorder. Is that common?
Yeah, I would say that's very common, and I think it really comes down on how you ask the questions. Really, you want to make sure that you build that alliance with your patient and let them know that you're there to support them. And sometimes when we ask those type of questions, they can come off a little offensive.
Yeah, I mean, patients often are very defensive about their drinking history. You may not even get that, what we got out of her. They might just be like, no, I'm fine, no problem. So it can be very, very tricky. What does alcohol actually do to your GI tract when you're a chronic user?
Yeah, so alcohol has so many effects, but in particular to your GI, it really causes hypersecretions in your stomach, in particular acid. And so once you start having all this acid in your GI, in particular in your stomach, it can start causing ulcers. And these ulcers can even be life-threatening if they perforate through the stomach or the duodenum.
So alcoholic gastritis, and then in chronic cases, we know it starts to create liver disease.
Yeah.
And then tell me a little bit about the tremors. What was that about?
Yeah, so the tremors is essentially related to alcohol withdrawal. So after we talked to her, her last drink was around 24 hours ago, and that's kind of when you start to see these signs of alcohol withdrawal. That's typically one of the early signs that you start to see. The other thing that really ticked it off was her vitals. She was tachycardic, so her heart rate was pretty elevated, which is also something else that people who are alcohol withdrawal present with.
So we see alcohol as a depressant. So when you take it all the time, your body's used to having a depressant around. When that depressant is removed for whatever reason, your body then has a excitatory state. Mm-hmm. And that's what this is manifesting, a high heart rate and tremors. And then, of course, one of the downstream effects is seizures, mm-hmm. and then full-blown delirium tremens, which is a very bad state of autonomic instability that patients need to go to the ICU.
Yeah, absolutely. Yeah, and the one I've seen in the ED, it's a life-threatening condition. It's really serious. So it's something important to be familiar with.
All right. Do you want to bring another student on?
Yeah, let's bring someone else on.
All right. Go raise your hand in the session there. So to clarify, that's a real doctor, a real medical student. The only actor is the patient.
Scarlett's actually going to medical school, but yeah. So, and that's a great simulation of like kind of the med student role with the attending physician role, and like the presentation and then the discussion and the feedback. So.
All right. So I just accepted a student in, and we'll see how long it'll take him to get in. And then what was the other thing? COVID-19, right? That was on the differential diagnosis. Obviously, before this whole pandemic, it would have been on the differential. How has COVID-19 changed the practice of emergency medicine?
I think that's a good question. So I've been on maternity leave for 3 months as a caveat. And so I was there with initial surging, and I'll be back in a week, which we're surging again. On a national level, it looks like actually initially patient volumes dropped in emergency departments because people were, I assume, scared to come in because of COVID-19. And so other things fell, but the COVID cases obviously rose. We peaked, and then it went back down and peaked in various parts of the country, and then is peaking all over the country again. And COVID patients are very, very sick. They can decompensate rapidly. And as far as I can tell at this point, COVID is not just a respiratory disease, but it really seems like a multi-organ like disease that predisposes itself to thrombotic events. So we see people with heart attacks, we see people with strokes, like we see people with blood clots, we see people with like all of these symptoms that and all of these organ dysfunctions that we think are attributed to COVID-19. So yeah, it looks like we have our student though. So I will go back to talking about our case.
All right. Hello, Jacob.
Hey, how are you? Can you hear me?
We can hear you.
Wonderful.
All right, Dr. Reno. Pimp him.
So I wrote down some questions. So first, I saw lots of comments in the chat that I thought were really excellent and really highlighted a couple of things. So first is talk about Will's bedside manner and tell me what you think about his question asking. And, you know, he had a slightly different approach than Dr. Lemry, and tell us what you think and kind of your impressions of that.
Well, to start, Will's bedside manner. At first, I kind of like when he first walked in, it definitely seemed something that would be characteristic of a med student, at least to me. The way he went through it, it was kind of methodical and by the books. But then thinking back on it, how he posed the whole question, like I have this questionnaire that I ask everybody, it makes it seem more broad. So like he's not singling the patient out. And it's kind of like he says, I do this for everyone. I ask everyone these questions. I'm not discriminating, which makes the patient feel more comfortable. Like they're not the only one being asked those questions. So they're more trusting with the questionnaire rather than just trusting a person.
And I really liked Will is like extremely non-judgmental when he's trying really hard to create a like a therapeutic relationship with her where she's comfortable talking about what's happening in her life and talking about her drinking. And so like, even when she's like, yep, I'm supporting local businesses, I'm going to the bar 4 times a week. Like, he's like, okay. Like he's not like, that's a terrible choice. Like 1, you're going to get COVID-19, and 2, like that is really not healthy, even in the absence of a pandemic. He literally just like rolls with it and moves on, and he's like very reaffirming to her. And I think he does a really great job of like establishing that relationship with her. And then later, you know, he can go and have a discussion with her like, hey, like maybe this isn't the choice that you should be making right now, and here are the risks. And there's ways to do that called motivational interviewing, but he does a really nice job of like just not projecting anything of what he's thinking and just being very non-judgmental and open to her. So I thought that was a really excellent job. So, and then, you know, when Dr. Lemry comes in, like he's already been given all the information by the medical student. And so he kind of covers some of it again with her, but he doesn't re-go through everything start to finish. And I think that's pretty common because at the bare minimum, patients sort of hate to be asked like everything 5 times in a row. And so, you know, he's already gotten that information from his medical student. So, what else, Ryan?
Ooh, what else? So it's interesting from my perspective. I'm glad that you caught the way that he presented the questions.
Thank you.
When we ask questions around drug use, around smoking, around alcohol, things that especially patients who may be addicted, who may have some of their own judgment around their use, they may feel attacked when you do that. And when you bring it up in a way that says, I ask everyone this isn't coming because I think you are an addict or I think you drink too much. This is just a question I ask everyone. So I really like that you caught that. Talk about, I saw some people wondering in the chat, the fact that he wasn't taking many notes, at least at the beginning. What did you think about that? And what are your thoughts around note taking with patients?
I think that's a good question. So, everyone is different. Like when I first started, particularly, like I used to be a very profuse note taker, and I don't know, I'm taking notes from your guys' comments while this is going on, and I just think that it's sort of individualized. Like I like taking notes, and so I do it a lot. I take a lot less notes with patients now because I just have done it so long that like I don't need to take notes anymore. Like I remember what is pertinent. The other thing is that I work with scribes, and so they're at the back of the room taking notes with us and writing stuff down. And so it's less important for me to like document in that minute because I have someone there doing that. I think there's like no right or wrong answer to this. It really depends on who you are and like what works for you best. I think med students tend to be pretty aggressive note takers, and that's great. Like, and then over time you probably sort of get out of taking notes because you like build the structure in your brain of what the disease process is, and you kind of know like what you need to fill in and what's relevant and what's not. So, but
I had a resident.
There's no right or wrong answer to that one.
I had a resident when I was a medical student who yelled at us, the medical students, because we took notes in a patient room. And he was like, if you went on a date, would you have to take notes to talk about how the date went? I'm like, there's a little bit different risk there if you forgot something. I completely disagreed with him. I obviously, as a medical student, I think it's super important you take notes because your brain is worried about 1,000 different things. And so we know our brains don't work as well. And then as you go as an attending, and the more efficient you get, and having a scribe definitely helps as well. So,
yeah, I mean, I've always been a big fan of notes. Like I still take notes during lectures, even though no one's going to test me on it, because for me, it helps me to focus and be in the moment.
Yep.
So,
Jacob, do you have any other questions about this scenario?
No other questions, but can I put in a plug for the WFR course at UC Denver?
I don't know what it is.
All right. So I guess 2 summers ago, this goes out to the audience. 2 summers ago, I took a course to get my wilderness first responder certification at UC Denver. And Dr. Gray and Dr. Reno were there. Great course.
That course. I know that course.
Stuff is over. Y'all should go take it.
I'm like,
it's not
WFR.
at UC Denver though. It's at UC Denver. Thank you. UC Denver is a separate campus, so it's at the University of Colorado Anschutz.
Gotcha. So. My bad.
That's all right. That's why I was confused. I'm like, WFR, Denver. I don't know, but thanks, Jacob, for coming on.
Yeah, thank you for having me. Great to see y'all.
Yeah, bye.
Nice to see you.
Well, awesome, Dr. Reno. We are at our hour. Any kind of last minute plugs? I told students just to go hang out with us in the Premed Hangout, which you're a member of. It's our Facebook group that we have. So instead of you being bombarded with one-off messages, we can just send everyone to the Hangout and have them ask questions.
Oh yeah, in the Facebook chat.
Yep.
Oh, guys, I'll get on the Facebook chat today and tomorrow. And go through questions. That's the first thing. The second thing I was going to ask is if you like these, if you would go to the website and watch all 5 of them and then give us feedback. You can get shadowing credit for it. you could get an actual certificate from the university, and there's like a $50 fee, but you can also just watch all the videos for free if you want. If you want a formal certificate from the university, we can do that too. And if you like them and give feedback, I'd like to continue to make them. You'll see me like 30 million weeks pregnant in the first couple videos, forewarning. And I like cannot breathe because the baby is huge. But we like to keep making them. And then if you guys think it's a good idea, I'd like to incorporate, we filmed a bunch of skills videos for the World Health Organization that I'm like the doctor teaching you how to do stuff like build tourniquets or like open an airway. And we have adult and pediatric like skills videos. And so if you think these are valuable, we can film more and then like have a skills video at the end, like here's, the first aid response in this, like how to clean a wound or how to open an airway or how to build a tourniquet or whatnot in terms of first aid. And so we'd love to keep doing these if you think they're valuable. But Brian, how do we give them the website?
I'll send emails out to everyone.
Okay. And we'd love your guys' feedback, and I will be happy to answer questions in the chat. And then anything else pressing?
I think that's it. I think everyone loved them.
Which is that coronavirus cases are spiking. And even though most of you guys are probably young, like we're seeing something called long haulers, which we don't really understand, but it seems like people can have chronic symptoms related to COVID-19, including myocarditis, which is an inflammation of the heart. And two, like, cases are picking up all over the country. Like hospitals are looking at implementing their disaster plans again. Like, I have a friend in El Paso who tells me their ICUs are full. Like, please, like be cognizant and be careful, not just for your own sake, but for your own community's sake. So that's my biggest request to you guys.
Wear a mask.
Yes.
Wear a mask. Wear a mother effing mask. It's a fun TikTok song. All right.
Data that if you wear a mask, you're more likely to have a mild case yourself. So, but
yeah,
I wear a mask everywhere. I literally wore a mask for 4 days when I was in labor with the baby. So
you can do it.
You can do it. I have faith.
You can do it. All right. Thank you, Dr. Reno, for coming on. Thank you, everyone, for coming. Again, eShadowing.com is where you all should go for all of your questions. Don't email me. I'll probably delete it because there are thousands of you. Have a great night.
Do you know our max?
What?
What was our max number?
Oh, I don't know. I'll get it to you.
Oh, okay. I want to know how many people we had.
I'll get it to you.
Okay.
All right. Have a great night, everyone.